Hello, I'm David Baldwin, a Professor of Psychiatry at the University of Southampton in the United Kingdom, and I'm pleased to have this opportunity to talk about anxiety disorders and their treatment in clinical practice. We all feel anxious from time to time, for example, associated with exams or job interviews or other changes in our life. But some people with anxiety have symptoms that are very severe and last longer than expected and associated with marked impairment of their ability to lead their normal life. And in this situation, they may be diagnosed as having an anxiety disorder. Anxiety symptoms are very common in primary care. This work from the United Kingdom was based on a questionnaire administered to patients before they saw their general practitioner. They completed the hospital anxiety and depression scale, which has 14 items, 7 for anxiety and 7 for depression. When we look at the distribution of the severity of symptoms, there's a rather interesting finding. First of all, with depressive symptoms shown on the right-hand side, there's what's called a continuous distribution, so that most people have depressive symptoms of only very mild severity. On the left-hand side is shown the picture of the distribution of anxiety symptom severity, which you see is very different. Some 50% of people sitting in their GP waiting rooms have symptoms of anxiety that are of possible or probable clinical significance. Now, this makes the task very hard for the general practitioner. If they decide who needs treatment on the basis of severity alone, it would be an arbitrary decision, as there's little difference between someone who scores, say, 10 and 11 points on the anxiety subscale. What people need to consider when diagnosing someone with an anxiety disorder is not just the severity of their symptoms, but also how long those symptoms have lasted and how much impairment is associated with those symptoms of everyday life. Another important consideration for the GP is to think about the extent of the severity of the depressive symptoms, because if depression is severe, this influences the choice of treatment that might be made in helping the patient improve. Anxiety disorders are very commonly comorbid in clinical practice. Now, comorbid means that the anxiety disorder occurs either at the same time as another medical condition or perhaps arising as a consequence of that condition. So in clinical practice, the commonest comorbidity of anxiety disorders is with major depression. In fact, it's often quite hard to establish which came first and which is the prominent disorder, whether it's an anxiety disorder or major depression. Anxiety disorders also occur very commonly in other forms of mental disorder, for example, in schizophrenia and in bipolar disorder, and of course many patients with substance misuse disorders also have anxiety disorders. In some cases, it may be that the anxiety came first and that people started to use drugs or to drink alcohol to excess to relieve the anxiety, unfortunately then going on to develop a secondary comorbid substance use disorder. There are many treatments available for people with anxiety disorders. In broad terms, there are 2 main forms of treatment, namely drug treatments and psychological treatments. When treating a patient with an anxiety disorder, it's important to think about, First of all, using a treatment that will get them well, and then continuing with that treatment to prevent an early relapse or a subsequent recurrence of anxiety symptoms. We know that people often have strong preferences for one form of treatment over another. So in clinical practice, it makes sense to ask the patient what their preferred treatment is, because psychological treatments such as cognitive behavior therapy or drug treatments such as a selective serotonin reuptake inhibitor have similar efficacy. They're as good as each other in relieving symptoms in the first stages of treatment. So patient preference is a very important consideration. If we think about drug treatments, most recent evidence-based guidelines recommend a selective serotonin reuptake inhibitor, or SSRI, for first-line treatment. And we would expect that about 2/3 of patients would respond to this initial SSRI treatment. The same would also be true if they were treated with a psychological treatment such as cognitive behavior therapy. Because treatments are established, many organizations have developed guidelines for the evidence-based treatment of patients with anxiety disorders. One such example are the guidelines produced by the British Association for Psychopharmacology. In the guidelines for generalized anxiety disorder, for example, there's clear statements about first-line treatments and then what to do if someone doesn't respond to that first-line treatment. For example, switching to another evidence-based treatment, switching to combination treatment with a psychological intervention such as cognitive behavior therapy, or maybe adding in another psychotropic drug treatment. The guidelines are also very clear that once someone has improved with a particular treatment, it's very important that they continue with that treatment for at least 6 months. Now, these guidelines were published in 2005 and were based on the evidence that was available at that point. More recently, longer-term studies have suggested that the duration of continuation treatment should be a little longer. In fact, it's quite likely that the next edition of the guidelines would recommend at least 1 year or possibly even 2 years after continuation treatment following a good response to initial acute treatment. We know that many patients with anxiety disorders will have a relapsing course of illness. So, for example, in a 12-year follow-up study conducted in the United States, about 50% of people recovered in the 12-year period, which, if you think about it, is not particularly good news. It means that 50% of people still were troubled by substantial symptoms even after 12 years. But the situation is even more complex than that, because if you look at the people that do recover within a given 12-year period, many will also go on to have a relapse of symptoms. And it's figures such as this which emphasize the need for continued treatment and concerted treatment to keep people well, because there's reasonable evidence from a number of anxiety disorders that if someone relapses, the next episode of illness is just that little bit harder to treat than the one before. Now, there are many certainties about anxiety disorders, but there are many areas of uncertainty as well. We still don't really understand why it is that a particular person will develop an anxiety disorder, whereas another person, when subject to the same stresses, does not. In recent years, there have been many advances in the areas of genetics, temperament research, neuropsychology, and neuroimaging, and these provide some understanding of the origin and maintenance of anxiety in healthy volunteers and also in clinical samples. But it's still hard to predict who would become unwell, which underlying disturbances of neurotransmitter function might underlie particular symptoms. And it's very hard when faced with a patient to decide whether they might benefit most from either a pharmacological or a psychological treatment, and within the pharmacological treatments, which particular treatment approach might be the most beneficial for that given patient. In recent years, the European College of Neuropsychopharmacology has supported the ECNP Network initiative. This network initiative comprises a number of research networks, the aim being to gather together clinicians and other experts with an interest in particular condition to help them undertake research that will explore the causes and the treatment of particular disorders. The Anxiety Disorders Research Network was developed some 2 years ago, and its aims are to gather clinicians together from across Europe and to involve them in collaborative research designed to, first of all, help improve understanding of the origin of anxiety disorders, and by joining together using collaborative databases and common research methodologies to help explore the origin of anxiety disorders across centres, particularly focusing on patient groups that are often excluded from other research endeavours. For example, patients with anxiety disorders and comorbid depression or comorbid substance misuse. We also have a particular interest in the lifespan nature of anxiety disorders. At the moment, it's uncertain whether initial intervention in treating an anxiety disorder will prevent the development of subsequent depression. Thank you very much.